Chris, I'm so excited to have you on our podcast. Tell us
Thank
about
you.
you and what you do.
Hey, well, I founded the nonprofit End of Life Psychedelic Care May of 2023, and here it is, December of 2024. It really has taken off. I think it really resonates. It's just kind of what we were just talking about, where there's a clear need and it's recognized. And so I actually do a lot of talking and have people do a lot of talking about ketamine, psilocybin, MDMA. Of course, we're all disappointed that the FDA did not approve MDMA. So there's other things that maybe I'll come back to and talk about that hopefully will help in that area. But there's three pillars I have. And one is education, really, really important. And so I do a series of free workshops for the public. So that's for the consumer and for anybody that's a professional folks like yourself who are in the field and they want to learn about psychedelic care at end of life. End of life, of course, we're talking about somebody with a life limiting or terminal illness. So I don't mean technically at the end of life, but just yesterday we did a panel discussion on spiritual and religious traditions. And so I had a Christian priest, a rabbi, a Buddhist, and a sort of Vedic scholar on talking about psychedelics. We talked about ancient traditions. So it's stuff like that that we're able to do for free for the public. Lots of different types of topics we've covered. And then we have the paid courses. I'm in the middle of what I call the core course. So 6 online sessions where we provide a foundational understanding. Today was Ben Malcolm, the spirit pharmacist, and he does consultations mostly relative to drug interactions with psychedelics, but also for medical conditions. And his whole topic today was relevant for palliative and end of life care. It's the kind of education that people really need in this space, I feel. And then our second pillar is to connect. So we were able to
Mhm.
launch a practitioner's directory this year, and it contains professionals who are trained in both end of life and psychedelic care. And then next year, I'm going to launch a online discussion group for consumers, whether or not they've already participated in psychedelic journeys or experiences or want to. So I'm really, really excited about that. And then advocacy, third pillar. And it's so
Mm.
exciting to be here in Oregon because we have the non-medical model, which means you don't have to have a DSM-5 diagnosis. There are some safeguards in place. There is the Advanced Illness Coalition made up of physicians that are looking to build these safeguards for individuals toward the end of life who want to go into a licensed service center. However, what we really are missing are the people at home, just what you were talking about. You go to where the people are. We would like to go to where the people are. So just starting the discussions on that. And in all likelihood, we'll put together a committee next year and begin to vet what's doable, what's possible, and find support within the legislature, and then maybe look to legislation in the 2026 session. So yeah, that's really, really, really exciting. And then the other piece of that is looking at the federal level, at least for me, because there's a Breakthrough Therapies Act, which didn't really move anywhere, but of course we had a pretty dysfunctional Congress. But what it allows for is, again, prescribing of any drug that's considered breakthrough therapy. And of course, both MDMA and psilocybin are considered breakthrough therapy. Fingers crossed, I'm going to go to DC next month and talk about it from the end of life perspective. So, I mean, just being able to do that is really exciting because, I don't think the lawmakers and the policymakers, they just don't know. What's really great about psychedelics on Capitol Hill are that it has bipartisan support. You know, everybody's rallied around the veterans. So, I'm thinking, why not rally around all of us? Because all of us are going to ultimately die. So wouldn't it be cool if when we needed it, it could be available? So that's fun. And then the other thing, I try to do anything I can to advance the field, but I'm really excited. In fact, I wonder if you did this for me. So I'm working with the University of Chicago researcher, and we published a survey, put out a survey to ask individuals like yourself, what is it like to work with people toward the end of life with psychedelics? So we're collecting that data and quite excited about what it might tell us about the current state, because this is another part of the problem. There are no protocols. I sometimes think about this. You practice the art of medicine. And so part of this is, what are some of those baseline protocols and safeguards that we should really be looking at? But also, where should there be the latitude to really support some of these people toward the end of life? And arguably, it's people get to make that decision for themselves, because we can even tell them, you might die during this psychedelic session or shortly thereafter. And if they go, "Pff, sounds good to me," then I don't think we should be in a position as a society to deny them of that right.
We provide MAID, the medical aid in dying, in our hospice as well. Same. If you got your faculties about you and you're conscious and you're like, yeah, I'm done suffering. I just don't want to suffer anymore. And that's one of my pillars is to decrease human suffering, just decrease suffering. And if someone comes and says, yeah, this is what I want, then do the assessments and the all the things. And if it's appropriate, then you go for it. We're sovereign beings and we should be able to make those decisions.
One quick story. This is a ketamine story. And so the physician that I referred to, who works in Northern California, and had a patient with it was cancer that metastasized, and it was end stage. I mean, he didn't have that much to live, and in fact, he had the medical aid in dying meds, whatever you want to call them, on the shelf. So he was prepared, and he was on the fence though. His pain levels were 910. The oxycodone, the opioids did not cut his pain. And what was really cool about the ketamine is he was pain-free during the session. The following day, he reported pain levels of 2 to 3.
Mm.
Phenomenal. But during the session, he released a bunch of trauma. He held shame around stuff that he had done to people. And so the first ketamine session I'm not saying he was 100%, but I mean, he was able to live with what he had done. But the last 2 sessions he used to come to terms with the maid. And he basically asked the medicine, tell me what you think I should do. And in both instances, it was, yeah, no, you're good with this. And on this last session, the third ketamine session, he also resolved issues with his son so that he felt there was closure there. But what was interesting to me too is he was a Buddhist and he belonged to a Buddhist community. And I don't want to put words in his mouth, whether it was shame, but he was afraid to tell his Buddhist community that this was what he was contemplating on doing, the medical aid in dying. So that was part of what he had to come to terms with. So what's so cool, yes, there was the pain, there was the trauma, there was these other things that, we call life. And he was able to resolve them because of ketamine.
That's incredible. That's incredible. So let's talk about that now that we're on the subject of ketamine. Kind of paint us a picture of how you see it being used in the space of end of life. How many sessions? Who's present? What are the practices that we see with ketamine right now for end of life?
Well, with the caveat that I'm not a medical professional, and I think I'd love to hear your thoughts on this, because of course, as hospice physicians, you use ketamine to treat terminal agitation and refractory pain all the time. You just don't use it for existential or psychological distress. So that becomes a sort of secondary outcome, right? But in talking to all the hospice and palliative care physicians I've spoken with, and folding in one of my favorite ideas, which is to bring end of life doulas onto the community.
Yes.
And what I like, I say, bring the medicine to where the people are. So they could be in hospice, for example, but more often than not, let's say they're initially under palliative care, or not even, but they've been confronted with a terminal illness, their mortality, and there are issues surrounding the fear of dying, depression, anxiety, demoralization, to name just a few. But then all the existential issues that surround that, learning how to let go, learning how to say goodbye to everybody and everything you hold near and dear. So if we can bring the medicine to wherever they happen to be, then, as you know, ketamine has several different routes of administration. So, what I like about it too, for people toward the end of life, if they're not able to maintain a sublingual troche in their mouth for 20, 25 minutes, swishing the saliva around, because it's hard for some people, then you've got actual rectal administration, which is really useful for people toward the end of life. You've got intramuscular possibility. You've got the liquid suspension that is easier to swallow. And I know that people are working on dermal patches to deliver ketamine.
Mm.
So, there was one company that was supposed to be, they thought it was going to be FDA approved this year, but I haven't tracked with it yet. So if a prescriber has all these different possible ways of delivering ketamine, then it really opens up the range of what's possible. For example, if there is somebody like this gentleman who was in deep, deep, deep pain, and I think significant doses of ketamine are warranted. The pain protocols are like, they can be 100 milligrams an hour over for 3 hours. I know a physician he administers 1,200 milligrams over a 4-hour period of time. So phenomenal doses, to
Mm-hmm.
relieve people of their chronic pain. So we'd like to see that. That's definitely, most of that would be in clinic. But as I said, this one palliative care physician goes in the home and he administers via intramuscular injection, and he's doing significant doses. I was a bit surprised. He's doing 0.7 milligrams per kilogram when all the studies were on 0.5 milligrams per kilogram. And he did a booster following that, did like a 15 milligram booster. And on the second session for this gentleman, he bumped it to 0.8 milligrams per kilogram and did another booster. So I think that latitude that prescribers, physicians in this case have is really helpful for the patient, because now you can treat a wide range of issues. So I think for the same gentleman too, because of the level of trauma, I don't think a small troche dose would have gotten him where he was going to get to. But then on the sort of other end of the continuum, perhaps, is an individual who is, not suffering from debilitating anxiety, but has a fear, has some issues, wants to maybe work out some issues with their loved ones, their children, whatever. And then you can think about psycholytic doses. Again, you can go into the home, or sometimes these kind of doses can be done remotely. So yes, I think as Dick Schwartz says, soften the parts, this time with ketamine, and be able to talk about the issues and come to some sort of resolution. So all along the way, severe debilitating depression and anxiety, I think higher doses. The severe pain, higher doses. But then if you don't need it, then the lower doses, or a lot of times these at-home therapies, whether it is rectal or troche or oral, can be taken on an as-needed basis to prolong the therapeutic benefit. Can I share another story?
Please,
Okay,
please.
so there was a woman in Sarasota where, that's where I lived, a friend of mine, and she was diagnosed with stage 4 head and neck cancer in 2016. Her resulting depression was so debilitating, she did not leave her house. And she turned to ketamine, and in sufficient doses and it was infusion. This was infusion. After the first dose, she felt the mood lift. After the sixth loading doses. So as you know, for severe depression, anxiety, then we do a series of loading doses because we need to get a lot of ketamine to the system. What is it? Short acting, long lasting, something like that. So after the sixth loading dose, she literally said joy. She felt joy. And she went out and got a job that she holds to this day. But the disease took its toll. And with the head and neck cancer and radiation on the jawline, what is it when all the tissue dies? What do you call it?
Necrosis?
Necrosis. Thank you. And she had horrible trigeminal neuralgia, and
Mm.
she also had neuropathy. So she was doing some booster or some troches in the home to kind of prolong the therapeutic benefit of the depression. But she turned back to ketamine in higher doses now for the pain, and is now able, again, with the help of some at-home dosing, rectal in her case, because she can't really tolerate
Mm.
troche, then she's able to maintain her job, manage the pain and maintain her job. So what other medicine would have been able to?
No, no, absolutely. And I think this is the area that isn't talked about as much with ketamine. You talk about the 8 sessions for the younger people who are depressed or not with a terminal diagnosis or existential crisis or anything like that. I think one thing about that population that concerns me is the addictive potential of ketamine, although in small percentages, it still exists. And I think it needs to be talked about. Just like I talk about psychedelics, and it's not for everybody. We have to be very conscious of how we use psychedelics, period. They are fire, so they give you warmth and life and food and all of that, but they can also burn down the house. And I believe this is where we're at in this realm of psychedelics is to be conscious of how we take our steps forward. And it's so wonderful to hear that we have more tools, right? More tools to use, especially when you're dealing with terminal illnesses and you have to face your own mortality. Not only face your own mortality, but also the discomfort of that diagnosis, whatever it may be. And as a physician, it really makes me excited to know that there are protocols and there's ways that we can help patients at their home, help patients connect, right? Connect with their loved ones to be able to forgive themselves and to forgive each other. And that's such a beautiful thing that these medicines also provide that peace, that inner peace. Because that existential crisis and anxiety really comes from all the things we've carried through life, is my experience. We've carried with us the
Mhm.
traumas, the whatever it is, wrongdoings, as you mentioned with the previous
Yeah.
story, but we have not resolved them in our reflection and we haven't examined them until, oh my gosh, I might die. And this is the time, right? And
Yeah.
most people have a short period of time and there's a lot of anxiety that can be coming from that. So that's, that's so interesting. So with the ketamine, 6 sessions or 8 sessions, which one are you seeing have more effectiveness or does it matter? Or does it depend on the
Oh,
patient?
okay, that's really a great question. And you can get into arguments with people about this. Low to mid dosing, higher dosing, sticking to no more than 1 milligram per kilogram dosing, and never going any higher. And yeah, the gold standard was always 6 loading doses over either 2 weeks or 3 weeks, followed by boosters. And it was always like 1 month, come back in 1 month. But you find a lot of physicians, a lot of prescribers out there, nurse practitioners out there, really feeling their way around this and doing what they feel is best. And it's hard to know because whenever you ask somebody, they'll say, "Oh yeah, it works. What I do works." And it's like you can't argue with them. But
Right.
I also know people that are doing it very differently. And so there's a nurse practitioner out in Maryland who actually working with people toward the end of life. She has her clients do 8 loading sessions in a clinic, and then she does low dose psycholytic ketamine and as a coach. I mean, she's kind of like you in the sense that here she was a medical professional, and then so she's not a therapist per se, but she would argue that that's not what her clients need, or that's not what any client needs as a therapist, that they need somebody who's going to coach them through their fear of dying. And she has very firm opinions about this. Okay, so it works for her. Okay. So I was just reading about a ketamine clinic in Portland that offers the 6 loading doses, but then they go into more like then one the next week, another one the following week, and then they start spreading it out 2 weeks, 4 weeks, and they claim a 90% success rate.
I agree with that.
There's a physician in California who likes to start out, and you'll hear this a lot, start out with a troche to gauge a person's receptivity to ketamine. I really like that idea too. I'm trying to remember the name of the physician. They had the ASKP3, the big conference for ketamine prescribers and psychotherapists, and he and his team are supposed to be unveiling what they found to be the new gold standard. So kind of like looking forward to having that when that hits, the airwaves to understand what that is like. So It's almost like there's no right answer. I mean, here's my palliative care physician buddy administering basically 3 sessions is what he does in the
Mhm.
client's palliative or hospice care. The doses I mentioned, and he again has great success. Now, could it have been different success? What are the markers? What are the parameters they're looking at? Um, but it's almost like there's no right or wrong. I mean, and if you're a psychotherapist, for example, um, then you can't do intramuscular injections. Clients have to do trochees basically if you're going to be there during the session. Or of course, as a therapist, you can support them afterwards. And so this may be controversial, but I'll say it anyway because I do believe in all the people I've spoken with and all the stories, the client stories I've heard, that you don't always need psychotherapy for people toward the end of life with what they're dealing with. Not saying never, I don't mean that at all. And if a person needs that, then they should hopefully find that support. But so many of the patients or clients are looking for relief for, like this gentleman just wanting to release the trauma. There was another gentleman with advanced stage ALS who actually passed before that third ketamine session was administered. First session was of him uh, running and playing with his children, so free from the shackles of his physical body that had turned on him. I mean, this was a man who couldn't do anything on his own, max assist. And that brought him joy. That's all he really needed was that. There was another young woman with end stage breast cancer who she asked to be able to experience what eternal life is. And she did. She basically said she was under a waterfall of what she felt was eternal light, just coming down
Wow.
on her, and that's what she experienced. So there is no psychotherapy associated with that. But again, if that's what somebody needs, then I'm hoping they can get that support. It's a long way to answer your question. Did I?
Love it. I love it. I love the stories and it's beautiful. It just it really makes you connect with them. The other question I have for you, have you seen any difficulty for physicians and Ps whatnot to prescribe ketamine?
Seen any difficulties on the part of the physicians because they won't prescribe or difficult journeys?
If it right, if it let's say a physician is taking palliative physician taking care of patients in at their home and they see that it's important for them to be I don't know, ketamine would be is indicated in this particular patient. Have you seen any people having any difficulty prescribing that from the board of pharmacy, from getting questioned, any of these physicians or MPs getting questioned when they are practicing on larger number of people, for example? Do you see that at all?
Well, I live in a bubble, Lita. I live in a world where I meet the people that are doing this work. So yes, I got to step back and go, wow, what is this? I don't even know if it's 1% of the prescribing practitioners out there for ketamine in the palliative or not even palliative or hospice care space. So yeah, there's huge issues. So many people don't understand it. I think that there are pockets. There are so many people I know in Northern California that are doing it that grows. If the community understands it and they get comfortable with it, then the docs in that community begin to understand it. There's other pockets around the country. But for the most part, no, these docs want nothing to do with it.
Right, right. So it's very interesting. It's very interesting, right? And ketamine is a prescribed medication. It is legal. And so then when you get into the MDMA discussion and the psilocybin discussion, it's true. And that's what I've seen in the past as well, where there's a lot of resistance in the physician community. Oh, it's not legal, so we're not going to even talk about it. So, but now talking about that, MDMA and psilocybin next is what I'm really interested in as well. But first, I want to check in and make sure you feel complete about your sharing about ketamine.
Oh, good.
Okay. So let's choose the next medicine. Let's choose MDMA. MDMA is the one, I don't know, I have not really come across much use of MDMA for end of life. And so I'm very curious to hear your expertise, your opinion, your knowledge around this.
All right, let's start with the clinical trials. MAPS, the granddaddy of the research facilities, MAPS, conducted one MDMA study for people with life-threatening illnesses, and they only looked at anxiety, but it was an N of 19. So it was a very, very small study. There was an outlier and one outlier. And so the results did not show a statistically significant reduction in anxiety. However, everybody did report a reduction with the exception of one person. So 18 people reported a reduction. A follow-up showed that it helped with one of the biggest things it helped them was coping with the ongoing realization that they have cancer, they may die. So that was a big thing. Their quality of life and their coping mechanisms were improved from the MDMA. So that was that one study. And so then fast forward to now, Sunstone Therapies, who's done a lot of work in conjunction with Johns Hopkins, is running an MDMA study for couples. So one of the dyad has to have cancer, and then it can be spouse, significant other, adult child, whatever, and they undergo the exact same protocol. And so they're hoping to show that some of the similar results in terms of anxiety and depression being reduced, but also improving the relationship. And what maybe people don't know is that prior to MDMA being scheduled as a controlled substance in 1985, therapists were using MDMA as a couples therapy. It's known as a heart opener. It's an empathogen. So, what it brings is self-compassion and other compassion. So as you can imagine, for people toward the end of life who are holding guilt about something they did, or they're kind of still mad at somebody and they want to resolve those issues, or you've got their family dynamics really suck, then MDMA can really, and so now then that's being done underground. MDMA is being used underground to help people with those things about the initial diagnosis is um, that you're not going to use MDMA closer to the person's end of life. So because of its impact on the heart. So, it's a medicine that you would use when the person is technically healthier as opposed to physically frailer. So that's a big caveat with MDMA. But yeah, you hear some similar stories with how MDMA has really helped individuals again deal with their guilt, their shame, and forgiving themselves and forgiving others.
Right, right, right. And it has such a huge role in complex trauma, as we know it. So, do you also know any practitioners? I know it's underground as far as MDMA goes. Do you know any practitioners that are using it in communities for end of life, let's say in those more healthy or earlier stages of people in their palliative and end of life journey?
I have to say, I don't know any licensed professional. I
Mhm,
know
mhm.
they're primarily end of life doulas that I know, and I'm not saying they don't exist, but the ones that I can think of who've shared their stories, yeah, they've been non-licensed professionals. That's not exactly true. There is a facilitator in Northern California who works with MDMA quite successfully. She's known to stack medicines for her clients. So there is one, yes. And then there are plenty of people though, but they're all doing underground work effectively.
Yeah, yeah. And yeah, another thing about MDMA that I've come across is the polypharmacy issue. There are a lot of medications that interact with MDMA at the high dose, and a lot of patients who are palliative and end of life tend to be on a lot of medications, unless they've decided that they don't want to be and whatnot. So yeah, that's another thing that I've come across with MDMA. Not people necessarily who are palliative, but who are having that existential crisis and complex trauma, who would be great candidates for MDMA treatment. But then they're taking medication that would interact, and I'm like, oh, I don't know. And then fear, right? A lot of it is fear of the unknown. What is it? And you don't want to mess with that. You don't want to harm people, of course. So
Yeah. Well,
yeah.
okay. So when I talk about people that I know that are really, really responsible in the work that they do. Without an exception, they have medical care teams that they consult with. I mean, one of the people is one I mentioned up front, Ben Malcolm. So that's his living now is doing consultations. And I would say if anybody's seriously contemplating something like MDMA and there's any question about their health or their medications that they're taking, yeah, seek out a consult from somebody, a physician, or like in Ben's case, a board certified psychiatric pharmacist.
I love that. I love that we have him available, because even as a physician, of course, I'll go by primary research, I'll look up all the interactions, and I have my sources. But then in practicality of things, sometimes it's different how things pan out. For an example, psilocybin and this serotonin syndrome that we keep talking about in people who are also taking SSRIs. Is it better for people to come off of the SSRI before a macrodose session? Sure. But when you really dig deep, there's actually no real research showing that it can cause serotonin syndrome. In fact, it's the opposite. In fact, it's the inhibition of the serotonin receptors that we're really concerned about and what we potentially see in the effectiveness of psilocybin. So the effectiveness of psilocybin goes down because you got an SSRI on board. Recent studies actually showed that even at high doses and having an SSRI, that wasn't really a concern anyways
Right.
anymore. It was a smaller study too. It was, I think it was, 45 or 50 people. But still, I think there's a lot of misconceptions that has been in the in this realm. I don't know who's put these fears out there for serotonin syndrome or these interactions that may not really be real, anyways.
Yeah, it is because people don't always make that distinction between what were exclusionary criteria in a clinical trial versus what is problematic in the real world. We know in a clinical trial they're strictly trying to regulate who enters that trial so they can show the best efficacy. So they're not going to allow other medications to potentially influence that outcome. And so, yeah, out go the SSRIs. Ben Malcolm speaks to this very eloquently. And he was the first one I saw when I read a report by him that said there isn't sufficient evidence, exactly what you just said, for serotonin syndrome. Now, do people think they're experiencing serotonin syndrome? Yes. And then there's a related phenomenon that often gets confused with it, that can happen. Again, people don't know enough to make that distinction. Another one of my heroes is Dr. Erica Zelfin, who spoke eloquently of the need to keep people on their SSRIs, that very often when they make people wean off of them, and they have all the withdrawals, they're coming into a session or a clinical trial with acute withdrawal symptoms, and they're miserable. And so better, she thought, to keep them on the SSRI. And on one video I watched, I think the quote was, she increases the psilocybin by about 30%.
When they are on an SSRI.
Yeah. And this is totally anecdotal. And then there's the belief, yes, there've been studies that have shown not only are the acute subjective effects when a person is on an SSRI during a psilocybin journey blunted, and then also the therapeutic benefit as assessed via whatever scales they're using afterwards. However, that's not always the case. One of my more recent pet peeves is Compass Pathways released a follow-on study to the big study they did on over 200 patients, where they administered 1 milligram, 10 milligrams, and 25 milligrams of psilocybin. And this was for patients with treatment-resistant depression. So not surprising was that only about 25% of the participants reported significant reductions in depression, because this is a tough group to treat, but nonetheless, at least 25%. But then they went back and looked at the data again and said that for the people they made to come off their SSRIs. There was a 2-week washout period.
Hmm.
They said there was no difference in the results between the people who hadn't been on SSRIs and the people who weaned off and had a washout period of 2 weeks. There was no distinction between their scores at the time of the weaning off to baseline, so right before the psilocybin dose, and then no difference after. And this was what, would make any person like yourself maddening. It's maddening because, all right, so now you're taking people who've probably, if they've been diagnosed with TRD, been on different antidepressants for decades. They made them wean off in 4 weeks. And they said there was no difference in depression and anxiety scores. Well, yeah, the meds weren't working anyway, so there wouldn't be. But, and I verified this through a pharmacist who really dove into the report. They didn't ask about any withdrawal symptoms. Are you experiencing insomnia? Are you experiencing nausea? Are you experiencing brain zaps? No, they didn't ask that. So, yeah. And who in their right mind would have a person take 4 weeks to wean off of a med?
No, my God.
So people who've been on meds for decades. So
No.
anyway, it was so problematic. People were like running around going, "Oh wow, look at you can wean off these antidepressants and you're fine." Blah 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 blah. So it's really really difficult, and well-meaning people wanting to share information, but it gets misinterpreted all the time.
Absolutely. In my practice as a coach, I have clients who come to me and they are motivated and want to come off of their antidepressants, whatever
Yeah.
it may be. Sorry, SNRI, tricyclics, whatever. And I tell them exactly that. I'm like, you've been on this for like 4 decades, like straight up 4 decades. And so we have to be very gentle. We have to be very conscious of how we take these steps. You're going to start feelings you have not felt maybe ever, because like you kind of forget, oh, I have feelings, I have emotions. The numbness that also comes from SSRIs, which people who do take them for a long time describe to me, and that's why a lot of them want to come off of it, or the fogginess, or maybe the fatigue, or not clear thinking is are the people that are motivated to want to come off. But you have to be so gentle. And I tell them, I'm like, you may come off of it and you may go right back on it, because it just, your body is now very much used to this substance on board, and that's fine. It's fine. There's no failure in this. There is, hey, I've tried this. I've examined myself. I'm examining my traumas. I'm looking at things in a very different way. I'm approaching life in a different way. And I'm a healthier person, because in my program, we do the conscious physician method with 20 conscious life practices. And then we will actually look into using medicine, microdoses or macrodoses, depending on what program people choose. But it's really the life practices
Yeah.
that change your life. The medicine is lovely to be able to peel back into the subconscious so you have access to saying, oh my gosh, these patterns I've been carrying for decades. They're not even mine. They're my parents', they're my grandma's. So they're my survival strategies that I used for a long time. And they don't serve me in my marriage. It's making us like dysfunctional, right? And so when we get into, I don't even use medicine the first like few sessions. We just hone in on the traumas, the conscious life practices, and the obstacles that come up for people to engage with their bodies and themselves. Like there's so much self-sabotage that comes about, and we examine all of that together as well. But that is the healing thing, to continue on that path. Now, I'm talking about not end of life, right? So you just don't have that much time end of life. And, I'm talking about most of these people that I have on my panel are either middle age or later in life, like 60s and 70s. I would say my age range it's gone pretty large, actually. Now I think about it, I have 20-year-olds on my panel who have had significant childhood trauma and who need and who were never taught life skills, and how do I care for myself, we don't have that guidance oftentimes. But yeah, I think 18 and up is really my client panel right now, all the way to the oldest 92 years old. But even with her, we implemented breathing, we implemented let's be hydrated. And she felt better and connection. How do I connect? Anyways, I digress. About end of life. Think what I've seen in my experience at the end of life is that because people are in such a almost feels a very authentic space. It feels like a very naked space because oh, now this is going on and my life is in danger imminently. There's a different part of the human that we're dealing with than I do when they're younger and not looking at an existential crisis.
Yeah, you remind me of a couple of things though, because even though there may not be a stated, oh, I've been diagnosed with a terminal diagnosis in the case of your clients, there's still at a certain age you might start to think about your mortality. And just an example for myself, I hit 70. 60s were great. Yeah, 60s were thank you. 60s were so good. But there's something about 70 that like every once in a while I go, that's like a whole different era. You can't say you're middle-aged anymore. You're over it. And so it does cause I think a person to go, mortality does loom a little larger. So yeah, I think there are existential issues that say in the case of your clients, would be worthwhile pursuing. But you also, when you asked the question earlier about physicians wanting to or reluctant about administering ketamine, something you just said reminded me. So it does beg the question, will we destabilize an individual who's already in a frail sort of maybe mindset, but physical health as well? And my answer, maybe it's not the right answer, but everything needs to be put into context. Goodness knows that the medications physicians prescribe for people toward the end of life have a whole host of side effects, negative side effects. And so is there potential for destabilization? And of course, that's not a black and white term anyway. Well, can it bring up trauma? Yes. That has to be dealt with. Can it really destabilize them? Sure. But what is that probability? Arguably, it's very low. These medications have shown, as you know, a very high safety profile. Ketamine is one of the safest medications around. Again, can it happen? Sure. Let's put it into context, and the person needs to understand it, make an informed decision, but that decision is theirs.
Yeah. Yeah. No, I love that. I love that. And I think there's a lot of fear that is instilled in physicians. And there is a fear of just fear, very fear riddled. The entire industry, they want us to be afraid. That's how you can control, right? Oh, fear of losing your license, fear of displeasing the system. You become a system pleaser. The way things are structured, the way the check boxes are in medical school and residencies, if you even like talk back at the attending and question them, maybe even in their knowledge, depending on the attending that you're dealing with, you may get berated or fail the rotation. And so
Wow.
people pleasing is what is, and fear driven people pleasing is what is instilled at a young age. And so I really like truly bowing down to the system and going by their criteria all along. That's how you get to the next step. And so it doesn't surprise me. I think those questions come from people who are just not in the know. Because I think if you do know the research, education, right? Your first pillar, that's my first pillar too. Our pillars are very similar, Chris. Education is huge. These conversations are huge. And if you don't know, connecting with people who are doing the work on the ground. And if you're not doing the work on the ground and you don't know the research, then I'm sorry, you can't talk. That's my whole thing. Educate yourself and connect with people who are doing the work and ask questions. Maybe go watch, be a part of it and see what is really happening. Because in these realms, a lot of healing comes about, lifetime of healing comes about. And so my next question is about I guess paradigm to talk about is the use of psilocybin. I know you had a webinar about microdosing. I still have it in the recorded session I'm going to listen to. And I was so curious to talk to you about not only microdosing, but also macrodosing at the end of life. Yeah.
All right, well, let's start with macrodosing. And we know from the research that the efficacy for reducing anxiety and depression, statistically significantly reducing anxiety and depression, is phenomenal, like 80%. Uh, and one study that came out of, again, the same Sunstone Therapies that is doing the MDMA study, they surveyed their participants 18 months after a single dose of psilocybin, of course, in this case, with associated psychotherapy. Fully 67% of the people still reported significant reductions in depression. Fully 57% of the people reported being in remission. So this is after a single dose of psilocybin. And that's what you'll see across the board. There are a lot of studies underway now that are really going to help inform the field in a much bigger way. So let me talk about that for just a little bit. The initial studies out of Johns Hopkins, UCLA, and NYU all looked at anxiety and depression. But now researchers are starting to look at things like existential distress and demoralization. So they're really trying to get more at, all right, what are the individuals facing when they have a terminal illness? And so they're looking at, I think, in a much more broad and a much more applicable way, at least trying to ascertain how it has therapeutic benefit. Similarly, as you might know, these studies also have shown that a mystical experience is correlated to the therapeutic benefit. So from my read, is my personal opinion, but I think one of the reasons that the psilocybin trials in this population have been so phenomenal is because of the mystical experience, because you're bringing in an individual now who is open to, listen, I want to learn what is it like on the other side. I want to know that there's more than just me, my physical body here. And so they're open, they're receptive to a mystical experience. And I think by being that way, you are. And arguably, maybe a cynic would say, what you're seeing or feeling is not real. And it's like, it's not up to us to tell somebody what's real or not real. In this case, it's like, no, I really believe that this is that we exist in a field of consciousness. I feel it. I've embodied it. So it brings that relief to people, which then, helps me to segue into a non-medical model, because of course the clinical trials are all looking for a DSM-5 diagnosis and, an ability to show that reduction in anxiety and depression. Well, it's a medical model, when in fact, for many of these people, it's not a medical thing, it's a spiritual experience, which is why I like that in Oregon, it's a non-medical model, which is why I like the work that underground people do when they do it safely, is that they're really helping people have these spiritual experiences. So, psilocybin is another one of those extremely safe drugs. And unlike ketamine, there is no potential, at least never seen yet, for addiction. And there is no lethal dose. Unlike for ketamine, there's a lethal dose. So it's very difficult, if not impossible, to overdose somebody on psilocybin. Now, they may not have a very good journey, but they're not going to die, and they probably will be no worse for the wear afterwards. So psilocybin, again, very gentle, very safe. There's other medicines out there that aren't as safe, and MDMA, we already said, is one of them, where you want to be careful of the impact on the heart, on blood pressure. So we've seen this over and over again from the clinical trials, very successful. So then the thing about psilocybin that's totally cool, as distinct from ketamine, and they're both good, is that psilocybin can bring issues front and center. So many times when you're talking to clients or patients who've undergone psilocybin journeys, they'll report seeing their cancer, talking to their cancer, having their cancer felt in their body. So a felt sense of the cancer, but having those conversations and coming to terms with their cancer. Hear that over and over and over again. And so one story is Thomas Hartle, who is the first Canadian who was approved for psilocybin therapy through Health Canada. They have a marvelous program, albeit filled with bureaucracy, but nonetheless, some 200 people have participated in psilocybin therapy, either one-on-one or group. since 2020. So Thomas was diagnosed with stage 4 colon cancer 2016. He participated right from the get-go, which was 2020. By the time he had passed, which was unfortunately August of this year, he had participated in 7 psilocybin journeys. And you could see this sort of like trajectory for him. And I don't mean to say it's linear, but it was almost like a Maslow's hierarchy where he really wanted to get rid of the debilitating anxiety, which I consider physiological. So to get rid of the debilitating anxiety, and then as he kept experiencing the psilocybin, began to raise his consciousness. He began to understand that we are all existing in a field of consciousness. And so two quick stories. So he came to call his cancer almost me, because the cancer said to him once, "Do you think I want to be here? I don't want to be here." And he goes, "Yeah, you know, you're almost me." And people talk about battling their cancer, but you can't fight a battle against yourself, right? It's not a fight you can win, is what he said. And so he really came to terms with his cancer in that way. And then one of the other just absolutely beautiful analogies he tells is of a tuning fork. So he says, think of a bucket filled with iron filings. What is it? It's just a bucket filled with iron filings. He says you melt those iron filings down and you can fashion a tuning fork. So what is that? It's just a thing. But he says you strike that tuning fork and you send that frequency out into the universe for eternity, essentially. That's what we're talking about. I am going to exist for all of eternity. So that's what he came to with psilocybin.
Wow.
Yeah. And he is so eloquent in describing this and had such an ability to articulate at a very deep level what he experienced that it's just wonderful. And I've got an edited video of him on my website that people can listen to. It'll make you cry because it's just so beautiful. So that's what psilocybin can do. And so if we look at Oregon and Colorado, by the way, so when I was talking earlier and I was talking about state level advocacy, Colorado is really important as well, because initially the rules, the ballot measure said that psilocybin services can be administered in the home. And it's called DORA, is their rules committee, is coming back and saying only if the client requires palliative care, which, as you know, and as I know as a former home healthcare owner, home healthcare agency owner, that's great, but it doesn't get to everybody. I mean, I took care of several young-ish adults, quadriplegics, that weren't able to leave the home, but they weren't under palliative care. And so there's a lot of people who it's going to leave out. So we'll see what happens. But in any case, there was at least the promise there that they'll be in the home care. So microdosing. I personally think it's really good in combination with macrodosing. So lots of people swear by microdosing, and many of the studies will talk about placebo effect. And I think when people are working with coaches like yourself, then they're implementing all those ancillary programs and maybe cleaning up some of their diet and exercise and all that. And yes, they're starting to feel better. And I fully believe in the neuroplasticity benefits of whether it's macro or microdosing. So over time, you still have that ability to rethink your thought patterns, but you said it. It's like your life practices have to be different. So it clearly helps. But what I loved about this microdosing workshop that Casey Garrett did was her anecdotal stories that it can help people with cognitive impairment. I'll put it that way. She never used the term MCI, but that it can help with cognition. So who knows? I mean, it doesn't hurt to try in this case. And now there are studies. There's at least 3 studies I know of, 2 with psilocybin, maybe even 3 with psilocybin, 2 in Canada, 1 at the University of Alabama in Birmingham. That's all psilocybin microdosing in patients in palliative care. And then there is Mind Bio is doing an LSD microdosing study down in Australia. So I think we'll be able to collect some data to see its efficacy in this specific population. But I think across the board with anybody I've ever spoken with, the best combo is macro sustained with micro. And with the caveats, the safeguards as you would know. I mean, taking breaks, and this isn't like,
Mhm.
oh yeah, I'm gonna do a macro dose, 2 months worth of micro, macro dose, 2 months of my, there is no
Mhm.
pattern. It's like, no, you've got to figure out what works for you and not overdo it like everything else we do. So does that, okay,
Yes,
yeah,
yes.
but there's so many studies now. And I'll tell you, because one of the FDA issues around MDMA was the blinding issue.
Mhm.
As we know, if you're saying, "Oh yeah, I clearly did not have a psychedelic," I think I read where some of the studies, 70% of the people broke blind. So the facilitator sitting there, even though they've been blinded, they can tell. But so there is a study that is being planned out of UCSF and UCLA for, again, people with life-threatening illnesses or cancer, but I think it's life-threatening. They're going to look at demoralization. Well, their active control is ketamine. So really jazzed about that. And I asked the principal investigator, Brian Anderson, and he said that the dosing is going to be zero point 0.5 milligrams per kilogram for the ketamine. And it was like, wow. Okay, so we both know that's a journeying
That's
level.
a journey. That's a real dose, you guys.
Yeah, so unless somebody's just really savvy to the distinctions between ketamine and psilocybin, and arguably it's different for different people anyway, breaking blind is going to be much more difficult. But the theory, back what I said up front, which is ketamine may be fast acting or lasting. Yeah, so as they continue to that, and then even if it does show, even if it does show
Mhm.
that the ketamine helped a lot of people.
Right, right. And I mean, why aren't we doing studies with, as you said, like MDMA and psilocybin, looking at, or ketamine and psilocybin, just looking at the side by side same protocol. What are you getting out of it? And of course, it's difficult because ketamine, it's just, I'm thinking about the route of administration, right? IM, IV, lozenges, troches, whatnot. And then, MDMA, you have a pill. With him, you have a capsule with a crystal. And then with psilocybin, it's a whole different thing. It's interesting. But I also think that we're looking at psychedelics. We need to change how we think about research and the double blind randomized controlled trial that we call the gold standard. How about we look at the individuals and see, is this changing your life for the better? Can that be the question? Search question.
Yeah.
Are you having less pain? Are you having a higher quality of life? Do you have more compassion in your life? Does psilocybin give you this with psychotherapy? Does MDMA give you the? Are you having better relationships? Are you connecting better? I think we also need to reframe how we do research. I think that's the old way of doing research. That's now just becoming stale because we see that it's not answering questions for us that we really care about.
Yeah. Well, because we know psychedelics are transdiagnostic, and so they don't fit neatly into a DSM-5. And we keep trying to cram it into that.
In the same model, in the same boxes as the previous generation of researchers. Of course, it's great to have those stepping stones, and we need all of that. But why can't we design something that fits the psychedelic ways that is really unlimited? As we're talking, that's really what it's coming up, right? And that's what I'm seeing. Even in my own program, for years, I've been telling my clients, I'm like, what I tell you is one way. This is
Mm.
one method. Every practitioner has their own way that works and it's in their purpose. It's aligned with them. And that's the practitioner you want to go with, of course, where you feel that alignment and harmony within them and they keep you safe. And of course, there are criteria to look at that as well. But to really allow for that, sure, there's certain things that work overall as best practices, but to also give people the permission of individuality of their own experience of life and quality of life and what that looks like for them. Yeah.
Well, let me ask you a question. Do you do that? Because microdosing strikes me as fitting exactly into that, where, of course, we talk about the Fatimi protocol, this Stamets protocol, And I think the best thing though is to train people to like trust their intuition.
Yes,
Yeah,
that's
that
what I
makes
do.
sense to me.
Yeah, that's what we do in my program. We sit, we go through, and initially there's layers of uncertainty, layers of, again, the trauma, the complexity of life that they've gone through, and we have to clear that out for them to find out who they are. And then once that peeks through, like, oh, this is who I am. Because you got to get through that first, those cobwebs first, to get to who am I?
Yeah.
And then when you
Yeah.
get there, then you can start listening. That's a discussion. Like I always see that in the very beginning with my clients. Hey, what is it that feels good to you? And a lot of them, they're like, I've never thought about that question. What does your body feel in this kind of situation? When do you feel a whole body yes? When do you feel a no? How do you feel that? What draws you? What does that look like to you? What does that feel like to you? And so once we get to that point, that's usually halfway through the program. And then I can be like, okay, we're gonna start trying this particular frequency, this particular dose. And then you have freedom in that. And we always do ceremony with even microdosing because we got to see the sacred in the medicine. And seeing the sacred in the medicine helps you see the sacred within. And so then I give them a little bit more, they hesitate in having more freedom and giving people that, hey, this is yours. And a
Yeah.
lot of times they're like, oh my gosh, this has never happened for me as a physician coach telling me I have freedom and I can make a decision based like taking something that is considered a medicine, whereas the prescription we write is so authoritarian,
Mhm.
and it's so top down that they're like, oh, have to, and a lot of people want to be good, right? They want to be good and they want to feel better. So they'll do whatever it
Yeah.
takes, even if that means take the medication twice a day. So giving them the autonomy and teaching them what that means is really interesting. Yeah, it's a cool journey.
Yeah. It's so much fun what we do.
I love it. So, burning question for me about Oregon's policies. So, here with the macrodose, you have to be in a facility. Is that correct? With a facilitator who's been state trained.
Right.
Yeah. And I hear that there's, of course, I'm sure there's a lot of red tape trying to get through in that process of getting that kind of a setup going. But yeah, what do you think about that? What are your
Well, I think we have to applaud Oregon for being the first state to implement a non-medical model, adult supported use of
Mhm.
psilocybin. And so, yes, they set it up with a lot of regulations, a lot of red tape. You have to participate in a licensed service center, lots of rules around that. But then also there's lots of great things where each psilocybin dose is lab tested. So, or at least each batch is lab tested so that people know what they're getting and they can feel confident in what they're getting. Um, the facilitators are state trained, so I think that's also a good thing. Then we're now looking at the potential for in the home psilocybin administration, but that's not easy. And you would know this as a physician, and I know this from running the home healthcare agency. You just don't say, oh, yeah, I'm going to start administering psilocybin in the home. Because, first of all, we're not talking about a one size fits all. Again, somebody who's much more physically robust after their diagnosis versus being really physically frail and the veil is thin towards the very end of life is not this, you don't treat them the same. So I'm thinking you've got to have triggers in, I'll say, the intake process, so
Mhm.
that if somebody answers a question a certain way, that triggers a medical review. If somebody answers a question another way, it triggers a psychiatrist review. So you difference a health condition versus maybe a psychiatric condition. And if then after that, there's a script that says you need a support person in the home, or you need to be monitored with a blood pressure cuff or something, right? Then we've got to do it. But I do believe that we shouldn't deny services in the home. We just have to be very careful as to how we go about it. And So we've got, there, Catherine Tucker is an attorney that does a lot of work in Oregon. She was instrumental in Death with Dignity in Oregon, first state to implement that. She also brought suit against the DEA on behalf of a physician in Seattle. His name is Dr. Agarwal, Sunil Agarwal. And so he wanted to treat his patients with cancer with psilocybin under right to try. So right to try, as you might know, allows a physician to prescribe a investigational experimental drug that has successfully passed an FDA phase 1 clinical trial and is now still in active study to be administered when, I think depending on the state, it's either like a year or less prognosis to live or 6 months and less prognosis to live. And so they tested it. And then the DEA refused to allow this physician to administer psilocybin under right to try. So Catherine Tucker was one of a handful of attorneys that brought suit against the DEA. 3.5 years later, we're still winding its way through courts. DEA, as you can imagine, intractable where it comes. So they're looking at two things. One is allow psilocybin under right to try or reschedule into just Schedule 2, which all that does is allow physicians to prescribe and makes it easier to do research. So we'll see what happens with that. But then she also brought suit against the Oregon Health Authority to allow for reasonable accommodation under American Disabilities Act for psilocybin in the home. So we'll see where that goes. The state's already fired their first salvo back. So we'll see where that goes. I personally think legislation is going to be the way to go there. And by that, I mean amending the existing law that's on the books for psilocybin. All right. You have a wonderful rest of your day. Lots of love.
You too. Bye.
Bye.